I know it's lunchtime and yeah, it's a pretty warm hall, but we're also talking about a very hot topic. So at the outset, I'd like to thank Dr. Nitin, who's been a good friend and a fellow marathoner. And I'll be talking about some of the newer investigative modalities, more specifically the tomography and ASOCT. Now, as we know that keratoconus has been classically defined as a progressive non-inflammatory thinning disorder of the cornea, which leads to ectasia and a disturbed vision, though we know that inflammatory factors are also important. And we also know it's bilateral, asymmetric. It has a increased prevalence, especially in our South Asian and Middle Eastern populations, with a strong association with allergy, atopy, eye rubbing, contact lens use and all. So it usually presents in puberty in the late teens and peaks in the second and third decades. But now in this era where we are doing more and more of refractive surgery and we have newer modalities which my fellow speakers will be talking about, so we need to diagnose keratoconus early. I will not delve into the pathophysiology, though we know about the abnormal collagenase activity and some of the markers and inflammatory markers, which the genetic factors, the environmental factors, they all get together, which lead to biomechanical changes and resulting in keratoconus. So the two hallmarks are thinning and ectasia. But when do we diagnose it? Clinically, we know some of the features, but I'll be focusing today on some of the investigative modalities. Now, these clinical features of established keratoconus, we've all been very familiar with in our undergraduate days, postgraduate days. And it's not that we always see these cases at an advanced stage. I think it's becoming a little less. But what we need to do is diagnose it as early as possible. So one of the important diagnostic modalities that we have has been the topography. We know about the Placido disc, the video keratoscopy, but this has been, it has stood the test of time. It's been there since the 19th century. But we know it images only the anterior surface. And we know that keratoconus actually starts from the posterior surface. So the slit scanning, which came out with the OpScan, which came out, that was the first instrument that was able to measure the posterior surface. Now, of course, we have the Scheimpflug imaging systems, various modalities. I'm more familiar with the Pentacam, and that's what I'll be talking about. So what do we look for on the tomography? There are various parameters, shapes, maps, and for a novice, it can be quite, confusing. The important thing is to identify that the patient demographic data has been correctly entered, because birth date is important because the parameters are, compared to the normative data. So after you've confirmed that the patient data has been correctly entered, the next thing that we need to look at is the quality specification. Has the scan been done correctly? Now, once you've seen this quality specification to be okay, then you can go ahead and say that this scan is reliable and you can further, delve into it. So just below the quality specification, you have the Q value, and we know that normally the cornea is prolate, but in cases of keratoconus, you have a hyperprolate cornea. And what I do is, after I've seen these two parameters, I come straight down to the Kmax and see what is the maximum keratometry. If it is above 47, it's already a red flag. But again, one needs to be cautious that not every K reading which is within the normal parameters is actually normal. So that should not, keep you in a comfort zone that just because the Kmax is normal, that this is a normal reading. You need to look at the inter-eye asymmetry. You need to look at what is the Kmax and the steep K. Is there a difference between the two? And you also need to look at the astigmatism. If there's a difference between your manifest and your topographic cylinder, that again is a red flag. You need to rule out, of course, that the scan has not misaligned because, or the dry eye, or the patient has not already been putting some dilating drops and then you've taken the scan, because these can be fallacies. The next thing I look at is the thinnest pachymetry. And we know that if anything which is less than 500, especially less than 470, again, that is considered to be abnormal. Now, one important thing is you need to look at the thinnest location. So the thinnest location, the y-coordinate, is it displaced? If it is displaced, the y-coordinate, if it is inferior, again, more than 0.5 mm, then again, that is a red flag. So after you've seen these particular things, then you go on to the 4 maps. And in the 4 maps, you first look at the sagittal curvature map. We've been familiar with the different shapes. We know that the shape can be either symmetrical, asymmetrical. You can have the skew or special shapes. But even what I would like to emphasize, that even a symmetrical shape, a round or oval or a symmetrical bow tie, can still be abnormal if the Kmax is increased. And some of the asymmetrical shapes can even be normal if you find that the superior-inferior difference is within normal limits, if the skewing is not there. So once you've looked at all these factors, the superior-inferior difference, the skewing of the radial axis, then again you can further think whether this sagittal curvature map is within normal or not. So this is a 22-year-old patient who presented with some disturbance in vision, and we found that his right eye had a high myopic astigmatism. We did his pentacam, and so here you can see the Kmax is more than 47, it's 57. There's an asymmetrical bow tie with an inferior steeping, and so this is a very obvious case of keratoconus. Now, next you come is to the elevation or the anterior and posterior floats. Now, again, over here, first you look at the overall shape. Normally, it's a central island or an hourglass shape. But sometimes you have these abnormal tongue-like extensions. Even though the otherwise all parameters may be normal, but if you have a tongue-like extension, again, you should be cautious. And then you need to look at the thinnest location, the elevation, which in myopes, it should be ideally less than 8 in the anterior surface and less than 18 on the posterior surface. So these parameters, you need to, just maybe put them up near your pentacam so that when you're looking at it, you can easily identify, or your technician can easily identify and, red flag anything which is abnormal. So coming to the pachymetry, we've already seen the thinnest location pachymetry. Again, you look at the overall shape, whether it's concentric or whether you have any abnormal shape like a droplet or a dome or bell-shaped. And again, looking at the superior-inferior difference is important, and also comparing between the two eyes is important. Now, we know about the best fit sphere, and the bad display, the Bellin-Ambrosia enhanced ectasia display, has really helped to highlight those subtle changes which one may miss on a normal best fit sphere. So here the thinnest location area, which is 3.5 to 4 millimeters, around that is excluded, and you get an enhanced best fit sphere, and then you look at the difference between the two. So again, here you can see that whether it is coming within the green zone, that is less than 5 microns difference, or you're having a more high, greater than 7 micron difference between the two maps. Seeing the D values can be misguiding at times. You may get a yellow or a red, but you need to look into it, why, at what point, what parameter is abnormal in it. And only then can you, further look at whether these maps are normal or abnormal. So just one parameter is not sufficient. You have to look at all of them. So as I also mentioned, the inter-eye symmetry is important, and you can look at these various parameters between the two eyes to see whether there's a moderate risk or a high risk. So in summary, there are many parameters to be looked at, and only when you identify all of them can you come to some kind of a conclusion. But there are fallacies, as I said, the image quality, the patient fixation, tear film irregularities, whether the patient has been wearing contact lenses, whether there are any subtle scars that you may have missed, all of these can misguide or mislead you. So the newer kid is the epithelial mapping. which there are several, articles about it, and Dr. Dan Reinstein has done stellar work in this regard. And basically, what they have reported is that the keratoconic corneas, they tend to have a donut epithelial pattern, which is, there's a compensatory thinning over the localized stromal surface, over the cone, and the surrounding area is thicker. So they had used high-frequency ultrasound, but now we all have OCTs which can help us to easily look at this. Normally, the epithelium is 50 to 60 microns, but they're in the center. But there's a difference between the inferior, superior, and temporal because of the eyelid mechanics and blinking. And in the keratoconic corneas, as I mentioned, there'll be a thinning over the cone and a thicker epithelium surrounding it. So basically, the epithelium acts as a masking agent over any of the stromal irregularities. And this remodeling is a dynamic process. And this can help us actually to differentiate the formfras keratoconus from the true ectasias and also, pseudo-ectasias. So here we can see that basically keratoconus starts from the posterior surface. And by the time it comes to the anterior surface, the epithelium may act as a masking agent. So we look at the profile on our OCT along with doing the pentacam. So here you can see that you have a case where the epithelium is normal, and in cases where you have a subclinical keratoconus, you have some differences on the topographic map, and you can see corresponding changes also on the epithelium. The pachymetry at times may be normal, but when you see the epithelium, then you find out that the thinning is there. So this is another case where you can see that there is an inferior steepening, and you may think this is a case of keratoconus. But when you do the epithelial mapping, you find that the epithelium is actually thick. So this patient is a normal case. He may have been a contact lens user. He may be having, dry eyes, which may be actually causing a thicker epithelium, and that may present as a inferior steepening. So these patients can be candidates for LASIK, which you may otherwise reject. So we need to, avoid the false negatives. We need to avoid the false positives, so that those patients who are actually normal are not falsely labeled as, keratoconus suspects. So the future biomechanics is another very, important aspect which we'll not be touching on today. But along with your topography, biomechanics has, now a very important role in identifying those cases who are vulnerable and maybe who need to be avoided as, candidates for refractive surgery. So the future would probably be of tier biomarkers and an increased role of artificial intelligence. But the importance of identifying these patients, whether your patient is a suitable candidate for refractive surgery, whether he's a keratoconus suspect, and whether you can intervene early in such cases and avoid more advanced keratoconus, that is the importance of adopting these technologies. Thank you so much.